We are.
Okay. So thank you very much for allowing me to come before you and talk about OneRx. That's the project name for the work we've been doing. And the acronym ONE stands for Opioid and Naloxone Education, and then RX referring to the pharmacy and the prescription. And though I am the spokesperson today for this project, I'm just one member of a large team that this work couldn't possibly occur without. So I'm just going to quick say thank you to my colleagues Mark Strand, Heidi Uckel, and Elizabeth Skoy that work with me here at North Dakota State University in the Pharmacy Practice Department. And then Jamie Steig, who is a community pharmacist and works with Quality Health Associates here in Fargo. And there's also a whole host of supporting casts that are really highly instrumental in making this program happen. So the title of this talk is Pharmacists and Opioids in Their Communities, a New Way to Look at a Long-Term Problem. And the sort of, if I had to put the goal of this project of OneRx into a sentence or two, I'd say it's to proactively help patients and communities by providing resources to the pharmacists in those communities to educate about opioid misuse and accidental overdose. So the project undertook to educate pharmacists so that they can educate their community members and their patients about opioids. And this is a new approach as far as the pharmacist's role. We're actually training pharmacists to do some screening, and that's not something that has typically been part of what the pharmacist does on a daily basis, but we're finding that it is so far meeting with a lot of great success. So I'm going to tell you a little bit more about the training we've provided and some of the results we're seeing. Objectives for our conversation today. And Lisa asked me to say if I would welcome questions throughout or wait until the end. I always prefer to have discussion rather than lecture at people, so please feel free to send questions at any point and interrupt me with anything that you want clarification on or that you would like to discuss further. And I have some questions built in at the end that I really am hoping to get some feedback and discussion going with you. So the OneRx program undertook to try to put a public health focus on opioids through the pharmacy window, specifically the community pharmacy. So we're looking at an upstream approach to opioid use disorder with this project, looking at prevention. How can we put a prevention lens in the community pharmacy? So we've implemented some patient screening, thinking about can we intervene and attempt to steer potential future opioid use disorder down a different path instead? Can we meet it right at the very beginning or even before it even gets started and send the use of that opioid, the patient's experience with that opioid down a different path than it might otherwise have gone? We're also looking at those that are already heading down the path toward an opioid use disorder. Can we catch it early and then stop the progression through referring patients for appropriate services? And then we're looking at can we prevent death from opioid overdose by providing the antidote to opioid overdose, specifically naloxone. So the program began by providing education for pharmacists, and this was a 3-hour continuing education program, and we were able to provide this training for free for all pharmacists in North Dakota who were interested. We would have been able to provide it for all pharmacists in the state, but not everyone took us up on it. So the 3-hour training involves kind of a reminder about opioid medication risks and benefits. Pharmacists are already familiar with this in some ways, but just kind of a refresher. We also did a lot of emphasis on opioid use disorder as a disease. Many of the pharmacists in our communities in North Dakota, were trained long before we started to think about opioid use disorder as a disease and certainly as a chronic disease. So just a little bit of reminder about the disease process involved. We train pharmacists to screen patients. I'm going to be showing you a lot more detail about that process in a few minutes. We train pharmacists to use a set of interventions based on their screening results. We trained them to provide and educate and also prescribe naloxone for patients for whom it was appropriate. We talked a lot about communication with patients, specifically focusing on using non-judgmental communication. We provided some motivational interviewing basics and practice. We talked about using open-ended questions instead of just providing information. And we talked about avoidance of stigmatizing language. And again, I'll talk a little bit in more detail about those a little later on. And then we provided each pharmacist who went through the training a OneRx toolkit and workflow set of documents that are all available online. And actually, if you wanted to, you could go and view them. They're available on the North Dakota Board of Pharmacy's webpage. If you just click on the OneRx logo, you can see that on the bottom corner of your screen right here. If you went to the North Dakota Board of Pharmacy's website, you'd see that logo on the right-hand side, and you could click on it and see all the materials that are used. They're actually freely open to anybody who wants to use them. It's not a requirement that you've gone through the training to access them. And then we also provided a 2-hour training that was along these same lines, but a little bit more abbreviated for pharmacy technicians. That logo on the right-hand corner at the bottom of the screen also is being displayed in pharmacies around the state of North Dakota, and it indicates that they have at least one trained pharmacist and they're utilizing the OneRx approach with their patients. So this is a basic model of the OneRx approach. The idea is that any patient who presents with an opioid prescription would undergo a screening process with their pharmacist. And that screening would involve evaluation for risk for opioid misuse, as well as evaluation for risk for accidental overdose, and then lead to a set of interventions based on what the screening results show. And we have trained pharmacists to use this process with every opioid prescription for every patient. And that means even those patients who are coming month after month to receive an opioid prescription, because we know that some of the risk factors that are gathered in the screening process can change over time. And so we did not want this to be something that's sort of a one and done approach or even a yearly approach that a pharmacist would engage with their patient, but it's every opioid prescription every time. So a little bit more about the screening process. So pharmacists are screening in order to gather more information about the safety of the opioid medication for that individual patient. And when they screen, they're looking to use the information to see if that individual is at risk for opioid misuse. And these are the things that they're primarily looking for. And this is based on a validated tool called the Opioid Risk Tool, as well as evaluation of the Prescription Drug Monitoring Report review. And the pharmacist is also screening the patient to look for risk factors associated with potential accidental overdose. You can see the specific factors that are evaluated there by the pharmacist. And the screening process is initiated by the pharmacist, either by handing the patient a paper form of the screening tool, so it includes an assessment for opioid misuse and accidental overdose in the same tool. Or it can be done electronically, and that's what you see on the right hand of your screen here, what the screening form looks like if it's done electronically. And that can be done in several different ways as well. The patient can scan the QR code with their smartphone and complete all the questions there. Or the pharmacy can provide a device that already has the screening tool up on the screen, like an iPad. Or the patient can sit down and complete it at a computer if the pharmacy has the space and capacity to have that set up in their pharmacy. And we were able to work with Quality Health Associates in North Dakota to set up a HIPAA-compliant version or platform, I should say, for this screening approach. And so it's all very seamless thanks to their help. We've trained the pharmacist to obtain this information from the person who's going to take the opioid or their representative. So even if the person themselves, the person that's going to be taking the opioid is not the one who's picking up the prescription from the pharmacy, we've also asked them to have that person's designee, whoever it is who's picking up the prescription, fill out the information to the best of their ability. And we recognize there are limitations to that, but we did not want all of the people who are not picking up their opioids themselves to be left out of this screening process. So as I mentioned, once the screening process is completed, the pharmacist then uses the information that's gathered to tailor a set of interventions for that individual patient based on what risk levels are identified from those screenings. And the platform that we have the screening set up on electronically calculates an opioid risk score that identifies the individual's risk for opioid misuse. And then the accidental overdose risk assessment is a little bit more of a subjective one, and I'll talk a little bit more about that as well. So the interventions that the pharmacists in the OneRx approach have been trained to implement would be, starting at the top, the partial fill. So recently, the federal government changed the laws surrounding controlled substances. Probably many of you are already aware of this, but this now allows for a refill to be placed on a Schedule II medication. So previously, if someone was filling a prescription for morphine or hydrocodone, they had to get all of that quantity that the prescription was written for, or they would just sacrifice their ability to get the rest, a remaining quantity if they only wanted part of it. Well, now the law allows for a partial filling of that prescription. So if a prescription was written for 20 tablets of hydrocodone, a patient could say, I just want to get 5 of those and see if I continue to have pain or if I will need them going forward. But that way I don't have so many at home if I don't need them. So the legal change has allowed pharmacists to discuss this with their patients, obviously a lot more. And now that's beneficial in a lot of ways. That makes it so that there's reduced amount of opioid that individual will have at any one time, reducing their risk for accidental or maybe intentional overdose. Also reduces their cost and reduces the amount of opioid that is out in the community that could potentially be diverted. So if you think about, raiding grandma's medicine cabinet, that's something that has been known to occur and increase risk for opioid overdose and just diversion of opioids out into community where they were never intended to be. So reducing the amount of opioid that leaves the pharmacy is one way to help reduce some of those risks. So pharmacists are trying to offer this partial fill intervention to any person who is prescribed a quantity of opioid that would last longer than 4 to 5 days. Many people end up with unused opioids, even if they partially fill their prescription. My son recently got his wisdom teeth out, and he was prescribed 20 oxycodone tablets. And I called my husband, who took my son to the appointment or to the surgery, and said, call me before you fill the prescriptions because I want to see how much medication he's prescribed. He was prescribed 20 oxycodone tablets, and I told my husband, don't fill all that, just fill 5 of them, and then we'll go back and get the rest if we need to. And my son ended up only taking 1 dose of oxycodone and didn't need any more. And so there's leftover opioid, and that happens a lot. And so pharmacists are now trained to remind patients about medication take-back programs and possibilities. So it's free to dispose of any unused medication, including opioids, in a medication take-back location. And this is a very secure way to make sure that those are being disposed of properly. The locations for medication take-back, as well as med-safe sites, I'll differentiate those in just a second, but the locations can be found at the website below. This is the North Dakota Attorney General's office, and they keep an up-to-date listing of all the locations where medications can be returned safely and securely. Take-back sites are located at law enforcement agencies, and unless otherwise noted, they're open 24 hours a day. And med-safe sites are participating pharmacies that have a bin for disposal of medications. Those may or may not be open 24 hours a day, depending on the pharmacy's hours. So pharmacists are trained to offer this intervention to pretty much every person who receives an opioid prescription. Naloxone. Pharmacists in North Dakota who have completed a training and registered with the Board of Pharmacy can legally prescribe naloxone whenever they deem it to have potential benefit. So we're training pharmacists to assess for accidental overdose risk based on some of those risk factors I showed you on a previous slide, as well as opioid misuse risk. And anytime either of those are identified, then the pharmacist is suggested to recommend the patient initiate naloxone, or have naloxone, not initiate it, have it on hand. And we teach pharmacists to talk to patients about this in a certain way, so as not to make the patient feel like they're being targeted or they're being stigmatized in any way. But so we encourage pharmacists to use the analogy that having naloxone in your home is like having a fire extinguisher. You have it around just in case something really terrible happens, but you hope you never have to use it. And that seems to be a very useful analogy for patients to understand that this is something that just makes sense to have around just in case if you're taking an opioid. So community support service referral is probably the most challenging area of the 1Rx program for pharmacists. As a profession, we traditionally have not been real great at reaching outside the walls of our community pharmacies. But of course, it's it's obvious that a collaboration between all of us is needed to provide the best care for patients who are using opioids, and especially those who seem to be developing problems with opioid misuse. And that's where this intervention really belongs for the pharmacists in the 1Rx, using the 1Rx approach, is when they identify signals, red flags, prescription drug monitoring patterns that indicate that there may be a problem with misuse. We are providing them with 2 different databases to help a patient locate behavioral health and/or substance use disorder treatment services in their area. And those databases are the FirstLink database as well as the SAMHSA database that have specific treatment locators that can be searched by zip code. So even in rural areas, you're able to find the closest treatment center that can provide the first assessment, of course, and then treatment services if necessary. The 1Rx training emphasizes that the pharmacist cannot make the call about whether a substance use disorder or behavioral health condition is present, but they can present their assessment about patterns of use to the patient and maybe to the prescriber as well, convey their concern about the patient's health, and then as a result, encourage the patient to seek help. So if you provide substance use disorder services and/or behavioral health services in your community, and you know a pharmacist, and you, especially if you know that they're one who is using the 1Rx approach, maybe you could consider reaching out to them to let them know that you've heard about this program and that you'd be willing to be a resource for them if they have questions or they aren't sure how to handle maybe a certain situation that comes up in their pharmacy. Because as I mentioned, this is sort of a stretch for a lot of pharmacists, and one that if they knew they had a community partner, it would probably make that conversation with their patient just a little bit easier. And then we also train pharmacists to provide information about opioid misuse, for every patient who gets an opioid prescription. There's a lot of misconception and urban legend and lack of understanding about opioids out in the community among the public. Many people do not realize that 1 in every 4 people who takes an opioid will struggle with misuse at some point in their lives if they continue to use that opioid. And that's even if they're taking the opioid exactly as it's prescribed in the initial going. So we feel it's important that patients taking an opioid have a clear and realistic expectation about their treatment plan with that opioid. And so we train pharmacists to ask them some open-ended questions about what they understand about the treatment plan with their opioid. How long is it intended to continue? What did your provider tell you about what you could expect for the control of your pain? Reminding them that a pain rating of absolute 0 is probably an unrealistic expectation from an opioid, especially a pain rating of absolute 0 for a long period of time while taking an opioid. We also train pharmacists to educate patients that sharing of opioids with others can be very dangerous and possibly even deadly. So reminding them about the opioid prescription is for the person it's prescribed for, and that's it. And we also remind individuals taking the opioid out of the pharmacy that opioids should be kept out of sight and possibly even securely locked in their home so that the risk for diversion is lower. So 1Rx pharmacists are trained to provide this information to every patient that's prescribed an opioid, and some handouts and flyers that provide more information about this 1 in 4 risk and some of the specifics I've just mentioned are provided in a handout that they can give to the patient. And those are available, again, on that Board of Pharmacy 1Rx website if you'd ever be interested in locating those yourself. I mentioned that we talk with the pharmacists in the 1Rx program about using non-judgmental, non-stigmatizing language. And research has shown that healthcare providers have a lot of stigma about substance use disorders. And depending on the study you look at, we as a healthcare team possibly even have more stigma about substance use disorders than does the general public, which I found to be quite alarming when I first came across that information. So we're training pharmacists to consider their stigma and biases and to curb any judgments they may have. It's not uncommon to become jaded or to be frustrated about being lied to by a patient or being concerned that you're being lied to by a patient. But we want to remind pharmacists that caring for their patients, has a lot to do with the way that they think about and talk toward their patients. And so we've gone through, this is part of the information we've gone through with them as far as how to communicate in a way that doesn't convey judgment and avoids using stigmatizing language. We train pharmacists to view opioid use disorder as a disease that needs treatment just like any other disease, like diabetes or cancer, and to communicate in that manner when they are working with any of their patients. So a little bit of information about OneRx results thus far. This is a little bit dated information. I have one update that I will add. As of January 7th, 2019, 136 pharmacists in North Dakota were trained using the OneRx approach, and 70 technicians have been trained. As of March 15th of 2019, 1,017 patients had been screened using the OneRx approach. 13.2% of those were identified as having opioid use disorder red flags. So those would be things like requesting early fills of opioids based on days supply previously filled, requesting cash pay, using multiple prescribers, or filling multiple controlled substances. Almost 28% were identified as being at risk for overdose, and that's the bulk of that was made up of accidental overdose risk, especially those that have conditions that predispose them to having some respiratory concerns like COPD and asthma. In 85% of those patients screened, medication take-back was discussed. 4.3% of those patients had naloxone prescribed and dispensed for them by the pharmacist, which is actually quite a lot above the national numbers that have been published recently. Somewhere around 1 to 3% of patients had been dispensed naloxone in other programs. So we were pretty happy about that 4.3% number. And the average time that the pharmacist spent with the patient in conducting the screening and the interventions was 4.92 minutes, just under 5 minutes. So we were also very happy about that, because some of the initial pushback we got from pharmacists, or some hesitancy in using the OneRx approach, was how much time it was going to take them. And once they saw that average of 5 minutes, then it no longer was a concern, and that didn't seem to be a barrier at all. Where you see the red pins on this map is where we have actively participating OneRx pharmacies around the state of North Dakota. So you can see it's a pretty good distribution all around the state. Chances are, wherever you are, you could get in touch with a pharmacist who's been trained with this approach. We do see some opportunities for future expansion and for improvement. So we're happy to see that 4% or over 4% of the patients screened were receiving naloxone, that a lot of them, the vast majority, were informed about medication take-back programs and MedSafe programs. But a concern that we have is that though pharmacists are finding red flag concerns or opioid use disorder concerns based on the opioid risk tool in somewhere between 4.6% and 13.2% of the screenings they're conducting. So the 4.6 represents an elevated opioid risk tool score, and the 13.2% represents red flags based on prescription drug monitoring profile review. Only around 0.5% of the time is the pharmacist contacting the prescriber. And so we think that that presents an opportunity for a lot of growth in collaboration, in interprofessional approach to caring for our patients who are prescribed opioids. A few next steps that the OneRx team is working on at the moment is incorporation of a OneRx approach into health systems and hospitals. This is a big project and has lots that we could unpack here if you guys want to talk about it more. But one of the things that pharmacists are asking us a lot that are engaging in the OneRx approach is, why isn't this happening before they get to me? Why isn't this screening happening before they come to the pharmacy with their opioid prescription in hand? And we think that to some degree it is happening, maybe not so much on a formal level where an actual risk score is being arrived at, and maybe that is also happening, but we haven't been able to get in touch with those who have described or told us about a specific and objective method that's being used for screening. And so our response to the pharmacists who asked this question is, that's where we want to move this. That's where we want to try to increase the activity, is how can we continue to expand screening in other settings so that it's happening maybe in duplication and maybe not, but maybe it's the location of the screening would be relocated. Another thing that we're working on is third-party reimbursement for OneRx services and outcomes. Before we started this approach, a pharmacist would not be paid for the time that they would engage in conversation with their patient. And in fact, they would sort of be disincentivized to discourage opioid use of their patients, because if they fill fewer opioid prescriptions, they don't make as much money. And so there's a bit of a conflict of interest if pharmacists aren't able to, be reimbursed for the interventions that they make in conversing with their patients and actually discouraging opioid use. So the grants that we have now are providing payment for pharmacists for conducting this screening and intervention. So we're working on gathering and publicizing the outcomes that we're seeing so that we can work toward this being a standard of care. That really is the goal, is that the pharmacist would engage in this kind of care always and with every patient, and maybe even beyond North Dakota's borders, but nationally. We're also having conversations with other healthcare professions about how this screening process might occur, or which of the interventions that are currently part of the 1Rx program might be expanded to other areas and other professions. And then, as I mentioned, thinking about expanding beyond our North Dakota borders. So I mentioned some discussion questions that I had for you. I'm just going to leave those there for you. I don't think I need to read through them to each one, or read through each one, but I would love to hear your thoughts about any one or all of these questions. So hopefully we can get some discussion going. But that does it for the formal content that I have to present about the 1Rx program.
Thank you, Amy. This is Lisa. I can think of about 1 billion questions, but I imagine other people have the same questions. The ones you have up here are really, really good questions, I think, but others may have additional questions. I'm going to start with just one that I had from pretty early on in your presentation. I was curious about whether the pharmacist has the ability to elect themselves to give a partial fill, or is it simply that they can offer that option to patients as part of what they offer?
They have to offer it to the patient. They cannot automatically implement that without the patient's acceptance. Okay.
So it's offered as an option and a tool in a part of this whole respectful approach that you're sort of espousing.
Of course, yes, and while it fits well with that respectful approach, it's a legal limitation that the pharmacist can't, sure, without the patient's approval, make that change.
Sure. So I'm going to turn it over and ask others to help contribute. I think we have a fair amount of time for questions. What comes to mind for people?
This is Robin. I just had a thought about the redundancy concern. I mean, I guess I in my mind, I don't think so, but I mean, we know that healthcare systems are supposed to be doing SBIRT. So we're supposed to be, doing screening and brief intervention. I mean, so we're supposed to be, asking these questions for patients to try to, we're supposed to be doing it universally. But obviously we try to get targeted with folks that, that we see some concerns about. But I also feel like these should be fail safes. Like somebody can get through, and it absolutely can happen. And also they might be coming in and refilling prescriptions, several times before they're going to come back and see their primary care provider and get screened again.
Right.
So to me, I feel like I don't see the redundancy in it. Maybe they did just get screened that day from their provider, but that's not always going to be the case. So in my mind, and like you said, new risks can come up. So, I don't know, if you go to an urgent care, maybe they look completely and thoroughly through all of the medications you take, but maybe not. And they may not have the same expertise that the pharmacist does in terms of seeing the risks. So from my point of view, I think that I guess I'm not worried about the redundancy part of it. I think it's really important.
Good. Thank you.
You could argue that this is our #1 public health problem in the country. And so I think many might say, Robin, that you should actually plan some redundancy in the system. And I think that if patients hear the focus on opioid safety and screening from multiple care contact points, it helps them to recognize that it's legitimate, and B, that it's really, really important.
I agree. What's so wrong with redundancy? I'm good with it.
Good.
And I'd like to add to that, this is Marvis, I'd like to add to that too, that the pharmacist has, it has such an important role in the whole interdisciplinary approach to treatment services for any chronic illness. And they take on a whole different kind of an expectation for a patient. I think of my own personal pharmacy that I use, and when I've been asked questions or comments about medication that my doctor has prescribed or whatever, I am really, really pleased by their interest and their their whole different approach. They're trusted. You know them. So I really think that that a pharmacist delivering this same kind of questioning that they might have just had at their physician's office or wherever they've been is just showing that interprofessional kind of approach that is so important in addressing this problem. And it is, I agree with Robin and with Elizabeth that this is not redundancy. This is the best of all possible approaches, I think, to addressing this problem.
Yeah, this is Dave Schmitz, also speaking, I guess, from a rural provider experience. And my rural health clinic was attached by 4 digits on my desk phone to the pharmacist or 2 of their techs in our small town. And I think my experience in that was, even despite our best efforts to coordinate, even within our town of 2,000, knowing what happened yesterday or at 1 o'clock in the morning in the ER, even amongst a small number of providers, a lot of times, well, it wasn't that infrequent that I would hear, but did you know that this patient was just put on Coumadin, by their cardiologist out of the big town, or, and so the opportunity, especially before the advent of, one computer source pop-up window, which doesn't always exist either, whether it's the risks associated with prescribing opiates or other medications, I really found it very valuable to have good communication between the providers prescribing and the pharmacists. And I think that was somewhat disrupted when insurance or other reasons, mail-away pharmacy became more common. To save a buck or 2, I don't know, maybe to save a lot, maybe so that patients in my county, which was the 3rd poorest county in the state, could afford food and I get it, and their prescriptions. So I guess my question is, does any of this expand? What is the national footprint of this? Does any of this expand to how many of our patients are getting their prescriptions around using mail order pharmacy, or is this more of a brick and mortar pharmacy experience for one RX?
Thus far, it's a brick and mortar pharmacy experience. That's a good question, though, about could it be done even in mail order pharmacies, or those who are with patients who are using a mail order pharmacy. My suspicion is that specifically with opioids, most of those, at least initial prescriptions, but probably many of the chronic prescriptions too, are not coming from a mail order pharmacy, though, that they are brick and mortar pharmacy more commonly.
And then, do you know?
This is Lisa. I was just going to add that most of the PBMs or pharmacy benefit managers that are affiliated with health insurance do keep a lot of metadata. They keep a lot of data, and they track opioid risk factor flags. And so, for example, in our plan, those are then often collated and forwarded to prescribers. But That said, I agree with everything Dave has said about why people use mail order pharmacies. The one thing that's not, that's just not ideal about a mail order pharmacy is what Marvis just talked about, the relationship that is had with the pharmacist in the community. And I think that many of these principles could certainly be used at the, in those mail order pharmacies, but I don't know, there is something very special about the way that your local pharmacist can interact with you. And I love the aspect of this, that it is medicalizing this problem. It is just like heart disease or diabetes or anything else, and your pharmacist can learn to talk to you about it in a way that's non-judgmental and non-stigmatizing. I really love that aspect of it.
I totally agree. And I was just wondering, is the North Dakota Board of Pharmacy working directly with the North Dakota Board of Medicine to make sure that, and our other boards, Board of Nursing for nurse practitioners, to make sure that everyone is well educated as to what's happening around 1Rx? Does anyone know that answer?
All I can speak to is about the Board of Pharmacy, that Mark Hardy has been really supportive of the 1Rx program. And I know he has a relationship with the Board of Medicine, but as far as how much 1Rx has been discussed amongst the Board of Medicine or presented there or anything like that, I don't know. I, as a 1Rx team member, recently reached out to the North Dakota Medical Association. Would that be the right? I'm not sure if I'm getting the title of the organization quite right, but
that's where I was headed to see.
Yep.
To see if I could present about this at their annual meeting.
Oh, good.
That would be a really good idea.
Yeah.
I'm still awaiting a response, but
Yeah. That's...
I had a related question to that, Amy, which was, are there ways that, if people on the call, people in the audience here, think that this is a useful service and a help to their patients, are there things that they can do to encourage pharmacists to become involved in this?
I would say simply having a conversation, and maybe your pharmacist is already involved with it, but if they're not, you might ask them about if they have interest in it, and if they have not yet enrolled, what's been standing in their way, what have been their hesitations, and just see if there's any ways that you could help to lessen any of those. It might just be I'm kind of worried about this and I'm not comfortable with it, and the more you talk about it, the more you describe experiences you've had that have been really rewarding in working with this patient population, the more we have found that it's been accepted. Also, we have found that a lot of our pharmacists, even the ones that have enrolled in this program, but especially those who have not, feel like it's not the pharmacist's place to do this. They feel like they're stepping on toes, they're going outside their territory, they're going to rub physicians the wrong way when they call to have a conversation about this. And so, we as the 1Rx team can try to provide reassurance and coach through how to approach conversations with prescribers and things like that, but they really need to have an experience or two that's a positive one. In a collaborative way, I think, and then they'll often see that, oh, this is not so bad, I can do this. And so just reaching out, I think, having a conversation, talking about ways you could collaborate is what I would suggest.
And is there a place where you can go to see which pharmacists at which sites? I know you had that little map, but is there a way people can go to look and see if a particular pharmacy or pharmacist is involved in 1Rx?
I believe that the list of enrolled pharmacies is available on the North Dakota Board of Pharmacy website, but I would have to confirm that. And it would not drill down to the level of the specific pharmacist. I think there would be mutiny, perhaps, if we if we publicize that information.
I was thinking, this is Robin again, I was thinking about the question of how we can, pharmacists in your community, best partner. I'm a mental health counselor. One of the best groups that I ever ran was on depression and diabetes, and my partner was a pharmacist. And I think that they're a huge untapped resource. And that was an amazing group because we were able, she was able to speak to the medication, and she was able to, speak to how this affected, and I was able to do my thing, and it was really good. And I've been talking recently with the chiropractor that we work with about starting pain groups and using different experts who can speak to different things. And that's actually one way that I really think that they would be useful, to have somebody come over and talk about these medications from that point of view, for people, because particularly pain, we need non-pharmacological ways of dealing with pain. So that's actually something that I'm really interested in. And that was probably a group of folks that I was going to make contact with to see if they wanted to be involved with it, even if it's just to kind of come and do some guest speaking.
I think that sounds like an excellent idea. I think sometimes the reminder from the medication person, the pharmacist, that medication is not always the best answer seems less biased than when it comes from the non-medication people. Do you know what I mean? So I think that's a helpful reinforcement, but it can, and can balance the pros and cons of medication versus non-medication approaches in the discussion. So that's good. Good idea.
So Lisa, this is Dave. I've got a couple others very specific questions, but I want to make sure our spoke sites have a chance to speak up if they'd like to in advance of that.
Yeah, I was wondering if we had any others who haven't spoken, who have thoughts about this. How does it strike you, or questions that you have for Amy? I know there are a lot of you out there. Somebody must have a burning question. Okay, Dave, I think your burning question goes next.
So I'm on the OneRx part of the Board of Pharmacy website, and there is a way that pharmacies can be receiving a level of recognition, and it's really clear laid out in the table there. So just so people are aware, it looks like there's actually incentive payment, and then subsequently there are levels at which you've done a certain number of screenings or have a certain percentage of your pharmacists and technicians who are trained in OneRx. So very well organized. You get a public announcement regarding your pharmacy participating. So I think that's really cool, very organized. And I do think, therefore, it then, from a rural provider standpoint, comes down to communication between the provider setting and the pharmacy, assuming the patient has the privilege of receiving their prescriptions there. But you can demonstrate that value. And so with that all in mind, and I'm pretty excited about this, it's really excellent. In addition to the number of take-back locations is really impressive. I can tell you the state that I came from, it was very hard to do medication take-back. It was like once a year and in an urban setting. So there are a lot more resources here in North Dakota than I would have thought prior to this presentation, so I'm learning a lot. Let me ask a couple quick questions. So I'm fascinated by the screening tool and how it might integrate with expert screening in a primary care setting or otherwise. I can think of a couple of things that might come up, so I just ask them in this setting if that's okay. What if people sort of answer most of the opioid risk tool questions, but not all of them? Noting that one of them is particularly sensitive, I think, the history of pre-adolescent sexual abuse. I could see where people might just leave that blank. How is the OneRx opioid risk tool or the assessment either put into the HIPAA compliant record, or is it just rejected in total? If a person, let's say, fills out everything except that question or the illegal drug question, I can see where maybe they might answer that at the if they've had the same PA for 18 years, they might tell that person verbally, but they might not also then replicate that checkbox or whatnot at the pharmacy around illegal drug use or pre-adolescent sexual abuse history.
Yeah, so if the individual leaves that field blank, then it's scored as if the response was a no. So that's obviously not getting then an accurate assessment of the full risk. And when that's been brought up in our trainings and on our team, my response thus far has been, even if they're reporting inaccurate information, the patient is, they're still reporting more information at the pharmacy than they ever have been before. And the pharmacist then has a lot more information that they can assess as far as risk factors than they ever have before. And if we don't start somewhere with these kinds of screening tools, then we'll never get anywhere. And so it's kind of, at this point, like with a lot of other screenings and assessment tools for risk, we have to rely on the patient to give the accurate information that they're willing to or comfortable with. And one step toward that is better than no steps, in my opinion.
Right, and thank you. I was just curious if the whole response set got kicked out or if you were still able to log something, so that's helpful. Yep. And then within the HIPAA law, then this is obviously information that can be shared between the primary care provider, i.e. the prescriber in a certain setting, or otherwise, even if it's a one-time prescriber in an urgent care setting or something, and the pharmacy. Is that correct? That information can be shared. So if there's an expert done in the primary care setting, and then the opioid risk tool is done at the pharmacy setting, those responses could be shared within the patient's medical record, correct?
Correct. They would not, most pharmacies in the community setting don't have any access to the medical record, so it would have to be a separate step that would be initiated either by the pharmacist requesting that information or the primary care provider sending it on, because there's just generally not access to the medical record in community pharmacies. There are some exceptions to that, certainly in the IHS, the dispensing pharmacists have access to the medical record, and in some health systems that is also in place, and at the VA it is. But otherwise, it's kind of generally not the rule.
But the primary care prescriber, let's say the primary care provider and or the prescriber could request the opioid risk tool information?
Yep, they could. Mm-hmm.
And then if that information has been provided by a surrogate, as you mentioned, the person authorized to pick up the opioid, is there an opportunity for, like, what if the surrogate says, yes, this person's using illegal drugs, for example? That's kind of a sensitive question for a surrogate to respond, whether or not it's accurate, right?
Right.
Does the patient have an opportunity to potentially review that response and or amend that response? How do you handle a surrogate checking yes to some of these sensitive questions?
At this point, the process would be that the pharmacist would assess whatever information is given, and then provide whatever extent is possible, provide the interventions that fit with the risk indicated with the surrogate. But then following up with the individual who's taking the opioid the next time they present, hopefully it would be them at the next point that they would present. But that's probably an imperfect setup at the moment, and we haven't had a lot of pharmacists coming to us with concerns along those lines, so I don't know how often that's happening. That's something that I should ask our pharmacists that are out in the field in the community pharmacies doing this more about that, probably, because we haven't run across any specific instances that I'm aware of that have brought up issues.
And I'm not being judgmental of whether it's appropriate or not. I just see that being a potential issue if the patient themselves says, well, no, that's not true of me or something.
Right. That's a good point.
Especially if, as a good primary care provider, I'm pulling the 1Rx opioid risk tool from the most commonly used pharmacy, and I see that that's been logged as a positive, but in my expert or otherwise patient record, it's shown as a negative. No. Mm-hmm. Then I might need to resolve that. Okay. And then slightly changing subjects, and I'll give it back to Lisa, is I understand this is changing the subject away from the tool. I understand some insurance situations will require 2 copays if you do a partial fill. And so a lot of patients are going to be like, I'm just going to take all 20 oxycodone because I don't want to have to pay another $10 copay, plus the hassle of having to go back to the pharmacy. And if I don't use it, blah, 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 whatever goes from there. And so you were saying that it can be less expensive to, do a partial fill, but I think some patients are experiencing that it's more expensive because the drug is cheap and the copay is a disincentive to a partial fill. Any comments?
I don't have any data-backed comments as far as how often the cost is reduced or increased, but you bring up a very good point that yes, that is a possibility depending on the patient's insurance provider and copay mechanism, that they may have 2 copays instead of 1. Yeah.
So maybe,
And I would just add to that I actually thought of that when you were first describing this. So thank you for bringing it up, Dave. That's true, that sometimes people will have to do a second copay. And I think for a lot of payers, there's work being done to reduce those barriers to actually reducing the amount of fills, because it doesn't make sense to make it harder for people to get less medication in these kinds of situations. That's a really good point, because it is a barrier at times.
Recognizing that pharmacists, it's an extra bottle, it's an extra label, it's an extra, there is more work being done. I'm not saying it's unfair, but it just is a disincentive.
For sure.
That's all I had.
Other questions that have come up for people? I had one other question I just wanted to raise. Amy, you actually raised this, but the question when you were presenting initial data from the project, one of the things you talked about was that the contact from pharmacists to providers when patients have screened at a level that caused concern has been relatively low. You remember that?
Yeah, I'm on the slide again here, yeah.
Here, we're like way ahead of me, sorry. Do you have thoughts about that, or do other people on the call have thoughts about that? I think about it, and it's kind of a head scratcher. I would love to hear from a pharmacist if somebody that I was working with screened positive or was creating concern. Is it time, or is there a sense of being intimidated, or that providers maybe don't think that pharmacists should be in the role of partnering in this way? Or do you have any speculation about that, what the barriers might be?
I've asked a lot of questions about this, both of our 1Rx pharmacists and of a focus group of providers, because I was very puzzled by it too. And I think it's some of both of what you said, time, but also a hesitancy on the part of the pharmacist that probably the provider already knows this. I'm just bothering them with their time. When I call the prescriber, all I can do is leave a message with the nurse. I never actually talk to the provider. Or when I do, they're irritated because they're like, well, don't you know that they have stage 4 cancer and they need this high of a dose of an opioid? That's one instance that a pharmacist relates to me. So I think there are some communication issues for sure that over time we can continue to work on, sand off a little bit, if you will, some of those edges. I also heard from a provider that they were sort of burned out on pharmacist phone calls, or contact, not based on opioids, but based on sort of some of the, I guess you would call it third-party incentivized things that pharmacists do that have to do with changing to a different generic that the third party has endorsed over another, like changing to quinapril instead of lisinopril, kind of getting burned out on those kinds of contacts from the pharmacist, and therefore not being real enthused about having additional contacts from the pharmacist, not knowing in advance when the pharmacist calls or contacts you, faxes you, whatever, that this might have a higher sense of urgency or something than those other types of contacts.
Okay. Well, I think that it probably makes sense that if you can get in front of the North Dakota Medical Association and begin to educate providers, and I think the more data you have, about what the project has done and what it has uncovered and intervened on. I think that it will start to overcome some of that, because the data is really interesting. It's really, it speaks for itself. And, when you talk about the fact that our pharmacists have been able to identify people who needed naloxone at a rate of 4%, whereas nationally it's lower than that. And the other things that they're finding, it may help providers begin to see pharmacists more as a partner rather than an irritant.
Mm-hmm.
And so I think that's a really good thing that you're doing.
Thank you.
So any other last comments? I think we're almost at 1 o'clock. Anybody come up with anything else? If not, I'm going to turn it back to Julie, because I think she had 1 or 2 announcements or things that she wanted to educate people on. But before I do that, I just want to thank Dr. Werremeyer again for coming on and giving us this really interesting education. Very, very helpful and interesting. Thank you, Amy.
And I just thank you all for your feedback and discussion. I really appreciate it.
Julie, did you have some information?
Yeah, just to let you all know, we will be doing, we won't be having an echo on May 8th, but we will be having one on I believe it's the 22nd. It's the fourth Wednesday of May, and it's going to be on healthy steps to freedom, and it's going to feature nutrition. Our presenter will be focusing on nutrition and how to use that as part of dealing with opioid use disorder. So I will be sending out information for that when I get everything gathered, and so keep an eye out for that. And otherwise, I don't have anything else right now. Just don't forget to do your evaluation post-test and send me your rosters, please.
All right. Well, thank you all for coming, and we'll see you next time.
Thank you.